Hello, everyone. Thank you for coming. Welcome to this session of NATO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Charles Hawley, NATO's Director of Projects, who will start today's session. Charles, you have the stage.
Thank you, Martin. Good morning, everyone. I appreciate you all joining our session today on primary care and networks. I'm actually going to keep this intro fairly short and hand off to Karl Finison, who will be moderating this session. Thank you, Karl.
Hi, I'm Karl Finison, Director of Analytic Development at Onpoint Health Data, and I'll be the moderator for this session. We have some really excellent presentations lined up on primary care spending from Maryland and Colorado, and a provider network analysis from California. After each presentation, there'll be about 4 or 5 minutes for questions that you can ask after each presentation. And at the very end, we probably will have about 10 minutes or more left for general discussion and questions as well. I'm going to start this with Maryland and turn things over to Dr. Emasealu, whose topic is primary care spending in Maryland. Dr. Emasealu is a preventive medicine doctor and works as a methodologist for the Maryland Health Commission. And so I'm going to turn things over to Ose.
Hello, my name is Dr. Emasealu, and I bring you greetings from the Center for Analysis and Information Systems at the Maryland Healthcare Commission in Baltimore, Maryland. Today, I'll be presenting our findings on primary care spending relative to all medical and prescription drug spending in Maryland's privately insured markets from 2017 to 2020. Highlights: I will briefly describe primary care within the U.S. healthcare system. I will then discuss the Maryland response to primary care promotion. I will also talk about the measurement of primary care spending and utilization in Maryland. And lastly, discussion of our findings. Studies published by the Organization for Economic Cooperation and Development in 2019 show that the US spends about 50% less on primary care services out of total medical spending compared to other industrialized nations. This has been described as one of the reasons why the cost effectiveness of US health systems continue to lag behind other industrialized nations. The key factors impacting the availability and utilization of primary care services include: 1, increased cost. In 2007, only 15% of the US population were enrolled in high deductible health plans, compared to 43% in 2017. Secondly, reduced utilization. The number of individuals with a primary care provider dropped by 2% between 2002 and 2015. Thirdly, reduction in primary care workforce. Studies have also shown that between 2005 to 2015, the number of primary care physicians dropped from 47 per 100,000 to 41 per 100,000. Maryland's response to promotion of primary care utilization includes the adoption of the Maryland Total Cost of Care all-payer model in 2018. Secondly, the establishment of the Maryland Primary Care Program. Maryland Primary Care Program is a key element of the total cost of care model. By the end of 2019, over 80% of eligible providers in Maryland had enrolled in this program. This program supports the overall healthcare transformation process, It also incentivized primary care providers to play an increased role in illness prevention, managing chronic disease, and preventing unnecessary hospital utilization. Third response by Maryland is the measurement and reporting of primary care spending and utilization trends. Studies have shown that quality measurement provides one of the tools needed for effective quality improvement initiatives. The objectives of this study was to assess the trends of spending on primary care relative to all medical and prescription drug spending in Maryland's privately insured markets. Additionally, this study also measured the effect of how primary care service was affected by the COVID-19 pandemic in Maryland. Now, what is the definition of primary care? We define the definition of primary care service was based on methodologies developed and published by the Milbank Memorial Fund in 2017. A patient encounter qualifies as primary care if the attending provider designated as a primary care practitioner provides services that qualify as primary care. Medical encounters for primary care were defined by select provider specialty using industry standard taxonomy codes. The providers include internal medicine physicians, pediatricians, mid-level health professionals, such as nurse practitioners and physician assistants. Primary care services were identified in the claims data using ICD codes and CPT codes previously published by the Oregon Health Authority in 2019 and published in the state of Oregon using the APCD database report. Examples of these services include encounters for routine health examinations, child immunizations, and routine home visits. Methodology. The data source for this analysis is the Maryland Medical Care Database, which is the private insurer portion of the Maryland's all-payer claims database. The study population includes Maryland residents under 65 years of age and enrolled in privately insured health plans. Only primary care spending for physician office encounters and hospital outpatient departments were included in this analysis. Inpatient or ERO visits were excluded in this analysis. This report also excludes self-insured ERISA and federal employee health benefit plans. This is due to Supreme Court ruling in 2016 and Office of Personnel Management barring payers from reporting data to the APCD. These data exclusions accounted for about 44% of the Maryland privately insured population. However, studies done by the Maryland Healthcare Service Cost Review Commission show that the MCDB data is still representative of the privately insured population in Maryland. This results slide compares primary care against all professional claims spending from 2017 to 2018 and 2018 to 2019. From 2017 to 2018, looking at the percentage changes, it will be observed that primary care spending per member increased by 8.2% compared to 1.4% increase in all other services for the same time period. From 2018 to 2019, primary care spending per member increased modestly by 2.7% compared to 2.6% for all other services. Nationally, percentage change in primary care from 2006 to 2016 was about 6.5%. Per member spending on primary care was found to be highest among children 0 to 18-year-olds and elderly 55 to 64-year-olds. Per member spending on primary care compared to all professional services combined declined from 13.2% among 0 to 18-year-olds down to 3.3% among the age groups of 55 to 64 years. With regards to trend over the years, primary care visits were relatively stable between 2017 and 2019. Higher visit counts were observed early in 2020 before the drop in visits due to the COVID-19 pandemic. This drop could be seen to have occurred around March, April, and then started picking up in May. By May 2020, there was another increase in visit counts, which was higher than the same months in the prior years. You will see from the graph, the purple line shows from July to October, the primary care visits for 2020 were relatively higher than the prior years. Primary care spending increased across all markets from 2017 to 2018 and 2018 to 2019. Percent spending on primary care was highest, 13% for the ages 0 to 18, as previously discussed. This high percentage could be due to the higher need for health maintenance visits at this age. Primary care alone constituted an average of about 4.9% of all medical and prescription drug spending each year. And this, as we described before, was comparable to national findings published by the Milbank Memorial Fund. Takeaways. Maryland responded to the need for an increase in primary care services by establishing the Maryland Primary Care Program in 2018. This program effectively took off in 2019 and has increased, and majority of the payers have participated in this program. The percentage change in primary care visit counts from 2017 to 2018 and 2018 to 2019 has been observed to have increased at a faster rate compared to other professional services. Primary care alone constitutes about 4.9% of all medical and prescription drug spending per year in Maryland, consistent with findings by the Milbank National Memorial Fund. Thank you so much for your time. I'll be glad to take any questions.
I'll say we have a question from the audience on why were ERISA and federal employees plans excluded?
Hi, thank you for that question. That's a very good question. So in 2016, there was a court case, Liberty Mutual, Gobill versus Liberty Mutual in 2016, where there was a Supreme Court ruling barring the states from requiring ERISA data submission. So this became voluntary, and essentially, most payers just did not submit. That data was not submitted to us. Then in 2019, there was also an OPM directive, also stating that the federal employee health benefit plan patients records for the federal employee benefit health plans, they do not need to report that data. So because of these, we removed these two categories because we suspect, incomplete data and inconsistency across the years. And since we are doing trends, we removed it across board. So essentially, these are federal directives.
Great. Thank you, Wesley. I think I'll ask, I don't see, here's another question. Why did you not look at the Medicare and Medicaid populations?
So the data we work with is primarily privately insured. This is privately insured data, and this is data that we currently house we have in-house. It's used for most of our reports. And this data is more timely compared to data we get from Medicare and Medicaid. And most of the studies which we found, if you realize that this particular study was designed after a couple of standardized studies done by Milbank Memorial Fund, and they had looked at privately insured. So we needed benchmarks. We needed to use privately insured and compare that with benchmarks.
Great, thank you. I'm not seeing any other questions at this point. I think I have a few, but I'll save them for the end. Why don't we move on to our next presentation? So our next presentation is Colorado investment in primary care through alternative payment models. We have Julia Tremoroli, Center for Improving Value in Healthcare, Civic, Maria de Jesus Diaz Perez. She's the Director of Public Reporting and Research, and Tara Smith, the Primary Care Affordability Director for the Colorado Division of Insurance. So I'll turn it over to Colorado at this point.
So hello everyone, and welcome to our presentation on investing in primary care through alternative payment models, year 2 lessons learned. My name is Tara Smith. I'm the Primary Care and Affordability Director at the Colorado Division of Insurance, and I'm thrilled to be joined here with my valued partners and esteemed colleagues at the Center for Improving Value in Healthcare, Julia Tremaroli, Katie Oberg, and Maria de Jesus Diaz Perez. So a lot to cover. We're going to jump right in. The division actually gets to work with Civic on multiple projects, but really the genesis of our work together, focusing on primary care, came from legislation that was passed in Colorado in 2019, and specifically House Bill 19-1233, which has the very technical and long, but also pretty descriptive title concerning payment system reforms to reduce healthcare costs by increasing utilization of primary care. So this is one where they actually got the bill title just right. Really, the goal of this legislation was to strengthen primary care as a foundational component of a highly functioning healthcare system here in Colorado, which is based really on the premise that by investing in primary care, we'll be able to improve care quality and health outcomes while reducing healthcare costs. So 2 provisions in this bill, which give us kind of 2 new tools in our healthcare reform toolkit here in Colorado. First, this bill created something called the Primary Care Payment Reform Collaborative. And this is a multi-stakeholder group that is facilitated by the Division of Insurance, but it brings together experts from the stakeholders that really have expertise in the field of primary care and are involved in the implementation of value-based payment models. So that includes payers, both commercial payers and public payers. So we have both our state Medicaid program and CMS, has providers, which in our case includes both family practice docs and pediatricians. And we also have healthcare consumers that are specifically tasked through the legislature with providing the state with recommendations on how to strengthen primary care infrastructure. The group also specifically gives recommendations to inform the second tool that you see here. This bill also directed and gives the insurance commissioner the authority to promulgate rules establishing affordability standards. So this is really a first for us in Colorado. This essentially allows the division to include affordability as one of the components of our rate review process in the state. So it's a new way that we can both implement and enforce something like a primary care investment target. So if you want to go ahead and go to the next slide. Kind of the third leg of the tool, I will call the 1233 stool. As we are increasing investments in primary care, we want to be able to measure that, and not just measure the spending, but then measure the impact as we're taking steps to increase it. So it's not let's just spend more on primary care and hope for the best. We want to be understanding what those investments look like. So another key component of this bill was to establish an annual report, which is why I get to work with Civic so closely, which they produce an annual report for the Commissioner of Insurance, and which we provide to the collaborative, which includes spending on primary care by commercial carriers, and then our state programs, the state Medicaid program and our children's health insurance program. And this report includes a percentage of medical expenses that are allocated to primary care, as well as the share of medical payments that are made through nationally recognized APMs, alternative payment models, and the share of payments that really just aren't paid through the traditional fee-for-service or on a per-claim basis. If you want to go ahead and go to the next slide. So one of the functions of the collaborative, like I said, they make recommendations that inform primary care policy in the state of Colorado. One of their key recommendations pretty early in their formation was to come up with a definition of primary care, right? When we're talking about investing in primary care and measuring that, what are we trying to measure? So the definition here, and I apologize for the tiny words on the slide, I think the overarching kind of theme here is that Colorado went with an inclusive definition of primary care. So you see the types of providers listed. We included family medicine, pediatric and adolescent, internal medicine, geriatrics. We also included OBGYN providers when practicing in a primary care setting. expanding the care team a little bit to also look at nurse practitioners and physician's assistant and also behavioral health providers when they're practicing in an integrated setting. So the formula here actually looks pretty simple, right? When you're looking at percentage of primary care, we want to be looking at what's being spent on primary care as our numerator and what is being spent total medical expenditures as the denominator, and looking at both the claims and the non-based claims portion of that. Simple enough. Turns out the devil is in the details, and so that's what I'm going to turn it over to my colleague at Civics to talk about how they have gone about the process and the lessons learned, and actually getting accurate data that reflects what you see in the boxes here. So Julia, I'll hand it over to you.
Thank you very much. So yes, collecting this data is certainly a pretty difficult task. And one thing that's important to remember is that there's two sources of information for this report that we provide to the DOI on an annual basis. One is the carrier-submitted alternative payment model files, which captures payments to providers that fall outside of the traditional fee-for-service structure, and that gives us a more comprehensive glimpse into actual total expenditures for medical care. But the other end of it is just claims from the Colorado APCD. So some carriers don't have to submit an APM file because they only reimburse on a fee-for-service basis, and we already collect that data. So we use the Colorado APCD as a source for that. That's just claims-based. So moving on to the next slide. We won't go through every part of this slide, but we've learned quite a few lessons as years have gone on. So we started this collection in 2019. And now for 2021, we've used a lot of the expertise that we have over the last couple of years to make some improvements in the data collection process, which includes adding a qualitative supplement to the APM submission, and then also just general improvements of the discussions that we have with the carriers and the folks at their organization who are able to speak to these topics. So going on to the next slide, we'll give more detail about the contract supplement. We won't go into super detail about each of these, but this is probably one of the more exciting parts of what we've added this year, which allows us to give the carriers a lot more detailed instruction and for us to understand those alternative payment contracts that carriers have with providers. So it's just a quick Excel sheet that we collect, and it's collected on the contract basis. And we ask yes or no questions. There's some that are 3 different answers, but basically asking what kind of services this contract covers, what's the mode of payment, if it's claims or non-claims based, if there's any quality metrics that are used, or if there's any spending targets, etc. And this has been a wonderful opportunity for us to learn more about these payments with providers. So moving on to the next slide, another lesson that we've learned, and this is just kind of a visual representation of the process that we go through for data collection. And this third one, so first is, well, I'll start with the first. First is we just collect test files, and then we validate those in step 2. But then that step 3, which also happens, it's kind of also a step 4.5 as well, is meeting with the carriers and their data policy team to review the results and go through the contract supplement. So this has been, we've learned a lot about what kind of questions to ask these carriers and who to be putting on the phone. There's still a lot of work we have to do in terms of having the right conversations with these folks, but that's one thing that we've learned quite a lot over the last few years that's super important. And then of course we have the production file submission and the validation. So moving on to the next slide, we've learned a lot of lessons. First is making sure that if you're going to collect this information, you have to define the denominator. There's been confusion about, should you include pharmacy, dental, and vision or not? We chose not to, but the first time we didn't really let people know that. So there was some comparisons between apples and oranges to other reports. Another one is just the implications of any sort of definition of primary care. We rely heavily on provider taxonomies, which sometimes can be different depending on carrier systems and what they source their information from. So that's caused some issues for us. Of course, as I already mentioned, the importance of continued conversations with carriers and building those relationships. Another thing is just making sure that there's consistency with the primary care definition with the carriers. And lastly is just this big puzzle of Medicaid. We've learned quite a lot with our discussions with our Medicaid agency, but there's always more to learn. So with that, we thank you very much for the time that you've spent. We have contact information on the very next page, and have a great rest of your time at NATO.
So I'm not seeing any questions from the audience. I'll pose a question, maybe a couple of questions. Pharmacy, understanding that's an issue, and several studies have included pharmacy and other studies have not included pharmacy. So I'll just pose that question. During this process, how did you arrive at decisions about whether to include pharmacy or not in the denominator?
Sure, I'm happy to jump in. Or
you go.
Yeah, go Tara.
presentation, a lot of the responsibility around coming up with our definition of primary care and kind of the initial way we wanted to measure it lies with the stakeholder group, the Primary Care Payment Reform Collaborative. So in discussing both provider types, services, taxonomy, who do we want to include, who did we not want to include, pharmacy, vision, and dental are part of those initial discussions. I think part of the initial reasoning behind not including it was to get probably a little bit clearer picture of what primary care spending looked like when you include pharmacy in denominator. That reduces the amount of of what is reported as primary care spending. So I don't know that you could call that decision final in the initial iterations of the report we've done, and if we've looked at the data so far. I think there's been value and help in not having that in the denominator, but that's certainly something that we're actively thinking about and discussing as a state, whether or not that is something to include. And part of that is also looking at other state efforts. And right, if as we have multiple states engaging in efforts now to both measure and report on primary care spending, there are benefits to having our data be comparable to other states or nationally. So I would say that is going to be part of an iterative discussion probably that we continue to engage in here.
Yeah, there is a question in the chat. Are you able to collect APMs? And I will add to that my own question. Alternative payment model information or payments it's really great that Colorado has a submission file definition for that. And my question also is how granular are you able to collect the alternative payment information, non-claims?
I can probably take that question. It's a wonderful question. So just related to Wade's question in the chat, we are not, at this time, we're not able to collect alternative payment model information at the particular member level. I think that would take a lot of parsing out to do, because there's certain payment arrangements that are inherently at the member level, and then others are really not. For example, infrastructure building payments, those aren't necessarily tied to a particular member. So what we've been doing is just collecting it in the last three years, well, 2.5 years, we'll call it. We're almost 2 days from now, it'll be fully 3 years. But we collected at the billing provider level. So we can still see a little bit of granularity into which providers are receiving these payments, maybe the spread of providers, what are the number of providers receiving these kinds of payments. And we do collect member month data. So if carriers, and sometimes they can't, but if carriers are able to attribute members to a larger provider and billing provider, then we can see at least that amount of information. And then we collected at both the billing provider level, and then we have this control total file that summarizes all that information. And we're pretty intense about collecting the member months information from that. It's kind of a complicated process. But we can at least report, what is the share of member months who are receiving care under these different kinds of models.
Right.
But it would be great to be able to do that in the future. I just don't know how.
It's exciting that Colorado's pioneering the way on some of this. So that's great. I don't see any more questions in the chat, so I'm going to turn things over to our California study comparing the performance of integrated informal provider networks in the California market. We have Dolores Yanagihara from the Integrated Healthcare Association and Jennifer Dodge, Senior Analyst at Onpoint Health Data. I'll turn it over to them.
Good afternoon. My name is Manuela Stanova, and I'm an epidemiologist for the Mississippi State Department of Health. I would like to thank NADO for the opportunity to present our work. The title of our presentation is Not All Hospital Care is Created Equal, a comparative analysis of ICU and non-ICU COVID-19 hospitalizations in.
Seem to have the wrong presentation up. Charles, can you pull up the California presentation?
Good morning, or good afternoon if you're on the East Coast. I'm Dolores Yanagihara with the Integrated Healthcare Association in California. Jennifer Dodge from Onpoint Health Data and I are happy to share with you this morning a study we conducted on identifying and assessing performance of informal provider networks in the fee-for-service market. Next slide, please. In California, there are hundreds of formal provider organizations that serve the managed care market. These are risk-bearing organizations that take capitation for at least professional services and some also for facility services. In the fee-for-service space, though, it is less clear how providers are organized. So the aim of our study was to see if we could identify informal provider networks in the fee-for-service market. These would be independently contracted clinicians that were acting like a group based on their referral patterns and shared patients. Our study was driven by Covered California, California's health benefit exchange, and IHA and Onpoint were privileged to also get guidance from Elliot Fisher of Dartmouth Institute. Covered California wanted to figure out how to encourage more integrated, coordinated, and accountable care in the PPO offerings of its qualified health plans. And they wanted to discover whether there are informal PPO networks that aren't affiliated with formal provider organizations. And if so, how their performance compared to more affiliated networks or formal organizations. With that overview, I'm going to hand it over to Jen to explain the methodology that we used.
Thank you, Dolores. We used the Integrated Healthcare Association's multi-payer claims database for California and collected over 200 million professional medical claims from 2016 through 2018 for members in preferred provider organizations and Medicare fee-for-service. We chose those groups as we know they have the most flexibility in their coverage because they don't need to stay within a pre-approved network. In all, this included claims for over 9 million California members. To avoid spurious associations, we eliminated claims that would not necessarily indicate a relationship between two providers, such as lab, radiology, imaging, and small surgical procedures. We also limited the claims to California providers only. Next slide, please. But first, we needed to define what a relationship between providers is. We started by conducting a literature review and found a previous study showing that physicians that share 8 or more patients are 80% more likely to have a validated information sharing agreement. So we limited our study to include only providers with at least 8 patients in common with another provider. We then assigned these 52,000 providers in the claims dataset to their respective core-based statistical areas, or CBSAs, using their zip code. CBSAs are a tool developed by the US Office of Management and Budget that uses population, commuting, and employment patterns to cluster counties into regions. And there are 29 CBSAs in California. Next slide, please. Finally, to construct the informal provider networks, we first created dyads of providers that shared 8 or more patients within a CVSA. We then used the Louvain function in the iGraph package in R to cluster the dyads together into networks. This is a simple method to extract the community structure of large networks and has been shown to work well with large data sets. The software repeats the clustering until it optimizes each network's modularity value, which is a measure of the strength of relationships within the network. And it ranges from -1/2, which indicates random clusters, to 1.0, which indicates strong clusters. All of our modularity values were positive, which indicates statistically significant groupings. Larger CVSAs had stronger modularity values, with the highest being 0.7. Next slide, please. Through our clustering analysis, we identified 687 informal networks of providers in California, ranging from 2 to about 3,600 providers. We then limited these results to only the networks that included at least 10 primary care providers, which limited our analysis to 163 informal provider networks across the state. This step was done to remove any networks of physicians that were groups of providers working in niche specialties and therefore would already be a known network. So now that we have our 163 networks, the 9 million members in the study were each attributed to a single network based on where they received most of their care. This was defined as the greatest number of visits to providers in a network with highest costs in a network as a tiebreaker. The 163 final networks ranged in size from 8 to over 400,000 attributed patients who averaged in age from 7 to 65 years old. Next slide, please. Once the final networks were determined, we linked to a database of California providers with information about their formal organizations to determine whether each provider was affiliated with a formal provider organization. Using this information, we could determine what percentage of each informal network was affiliated with a formal provider organization. In some networks, it was clear that a single formal provider organization dominated the makeup of the network, while in other networks, there were many formal provider organizations represented and no single organization dominated the network. And in still others, most of the providers were not affiliated with any single organization. From there, we categorized each network into one of 5 categories of affiliation, based on the degree to which providers in the network were affiliated with a single provider organization. Where more than 50% of providers were affiliated with one provider organization and less than 20% of providers in the network were not affiliated with a provider organization, the network would be classified as strong affiliation with one provider organization. Once the networks were categorized by affiliation, we calculated 26 quality, cost, and utilization measures for each of the categories. And now I'll hand it back to Dolores for our conclusions and next steps.
As Jen mentioned, performance results on a set of 26 clinical quality, utilization, and cost measures were calculated for each informal network and then rolled up to each of the 5 affiliation categories. You see a subset of the measure results in this table. The table is color-coded, with the darker green shading being the best performance and the darker red is the worst performance. You can see from the shading that for the clinical quality measures in the middle of the table, less affiliated informal networks generally perform worse and more affiliated networks perform better. The pattern is not quite as clear for the utilization and cost measures on the right side of the table. You still see the least affiliated networks performing poorly, the red, but the networks with some affiliation also perform poorly. And you see a lot of greens in the lower affiliation levels of somewhat unaffiliated and mixed affiliations. Next slide, please. This graph brings cost and quality together into a value equation. The x-axis is a composite score of the clinical quality measures, and the y-axis is the geography and risk-adjusted total cost of care in dollars per member per month. The highest value performance would be on the bottom right of the graph. So better clinical quality and lower total cost of care. And that's where you see the HMO benchmark, that red dot. For the affiliation levels of the informal networks, the darker the blue, the more affiliated the networks are. And you can see the clear progression from lighter blue to darker blue, or from less affiliated to more affiliated, as you move from left to right toward better clinical quality performance. However, you don't see the same clear pattern when moving from top to bottom toward more affordable care. And clearly, none of these affiliation levels compare to the performance of the HMO benchmark. Next slide, please. So circling back to our original questions guiding this study, were there informal networks not affiliated with formal provider organizations? And if so, how do they perform? The answer to that is yes. There were informal networks of primarily unaffiliated clinicians. In terms of performance, the unaffiliated informal networks did not perform as well as more affiliated informal networks on clinical quality. And none of the informal network affiliation categories compared favorably to the HMO benchmark of capitated formal provider organizations. For the policy question that Covered California wanted to explore on how to encourage more integrated, coordinated, and accountable care in their qualified health plan PPO offerings, we found that there's a big chunk of the PPO population that's not currently cared for by the formal provider organizations. So there's opportunity there. There are some legal restrictions to be mindful of related to contracting for PPO members, but we did identify some informal PPO networks of varying levels of affiliation that could be assessed further for contracting potential. And an ACO structure is one possibility for that. And now Jen and I would love to answer any questions that you have.
Thank you, Dolores. We do have one question, and then I have one as well. This question is, can you clarify the source of the database of California providers and their affiliations, please?
Sure. Yes. So the main database that we used was IHA's multi-payer claims database. And then we linked that with the definitive health care database to understand the affiliations with different provider organizations.
Great, thank you. My question is, for this type of provider network analysis, this type of statistical analysis from claims data, at least in my experience, has been less common. I have not seen a lot of this. How could this be used more widely in other states or for other payer types like Medicare or Medicaid? And what would be the benefits of a wider use of network analysis for this or other types of policy questions?
Yeah, I'll give a start, and then Jen, please feel free to add in. I think one of the things that we've grappled with in the PPO space or the Medicare fee-for-service space is it's individual clinicians. And when you're trying to assess performance of an individual clinician, it can be challenging just from a numbers perspective to get, good, reliable information, just because you don't necessarily have enough patients that meet a particular criteria for a particular measure. And so having a way to group physicians into some kind of a grouping or affiliation was the idea here, to see, are there physicians that are actually working together already in the way that they're treating their patients, even though they're not legally a group? And could that be a way to assess performance and even to consider contracting as we look at more APM kinds of contracts? Could those informal groupings potentially come together and contract in an ACO type of a contract? And so that's what Covered California was really looking at. And I think, it is a question that we have to grapple with in terms of how do we really understand what's happening in a space that's not as organized as, say, an HMO market where there might be groups of physicians that are caring for patients.
I see we have some more questions that have come in. Jen, did you have any response to that first one that you wanted to add? Or?
Yeah, I have thought about this a little bit, and it's a great question, how else we might be able to use this. And I think one of the thoughts I have is around looking at a population for which care is not always well organized, such as a specific population such as opioid use disorder. If we were to look at, do a network analysis around providers that provide that kind of treatment, could we identify networks of providers that are providing care for that population in an organized way, and what are the treatment outcomes for that population? So that's another idea I have around network.
Okay, we have a few other questions. Thank you. Could you or did you overlay the Medicare fee-for-service ACO structures to the provider networks, e.g. MSSP, NextGen?
That is a great question, Jill. Hello, Jill. And we did not do that. That's a great idea, though. I think we were focused a bit more on the commercial side in terms of the outcomes, but I think that would be a great way to understand affiliations that are currently existing as well. So thank you for that.
The next question is, what was your stakeholder engagement process? Were you able to engage providers in validating, verifying your methodology and/or output?
We did not have a stakeholder engagement process for this particular study. Obviously, when there's any kind of accountability uses of this kind of information, we would have a stakeholder process, but this was really based more on an internal study. There was a lot of internal validation, and I'll let Jen speak to that in terms of just really kind of, I looked at it just based on my information and knowledge to see if things looked reasonable, but there was a lot of Googling and things like that that Onpoint also did to look at reasonableness. So Jen, do you want to speak to that?
Yeah, we absolutely took every network that we created, we took a sample of them and literally went and Googled some of the providers in the network to try to understand, this is before we did the linkage to the provider database, to try to understand, does this make sense? Are we seeing a group of providers here that could be connected? Do we see patterns where a single provider organization dominates? And we found that, just with that kind of validation, it was borne out when we were able to link to the full database.
Okay, I'm not seeing any other questions. We had some additional questions come in on the Colorado presentation, so I wanted to return to those if we still have the Colorado speakers on. And I hope I get all these. Can you comment on whether Colorado's definition is similar or different to other studies? Is there a movement to standardize to enhance comparability across states?
So sure, I can jump in on that one a little bit. I think the answer is yes and no. It depends on the state, right? I used the word that we had arrived at an inclusive definition of primary care. I think the terminology you hear more commonly when you're talking about states' definition is whether you have a narrow definition or a broad definition. So some of the larger studies that have actually looked at primary care across different states, the National Primary Care Collaborative did one, Millbank did one, actually will show you the ranges, right, of what that percentage is being spent on primary care looks like, whether your definition is narrow or broad. And so more specifically, I think we are matched pretty closely with Oregon, right? That's another state that includes OBGYNs, that includes behavioral health providers, that has some of those other categories. I think those are probably the biggest two that states kind of either go or don't go. I think things like primary care and internal medicine are fairly standardized across states. And I know there has been discussion at the national level about what does that look like to kind of standardize that definition across different states, which I think is something Colorado is interested in. I think a complicating factor for us is we're moving forward and we'll continue to iterate on this definition. Once you have a definition and you put in place all of the procedures that Civic has described in those lessons learned, there's just a lag in operationalization of those, right? In terms of putting in new guidance, or how you're collecting a specific data point. That I think is something that we're mindful of as well, right? We use this definition to actually set a primary care investment target. Mm-hmm. And so now that you're holding commercial carriers accountable, we need to be a little bit more thoughtful in how we're iterating on that definition and our ability to actually be aligning with other states, but that's certainly of interest to us.
Great, thank you. We still have some other questions that came up after your presentation, so I'll go through each one. Are you able to display a combined cost in primary care spending, or is it always presented as APM spend and FFS spend?
The answer is yes. We do that. The whole process that we go through to collect the information in the first place, we separate between primary care claims-based and primary care non-claims-based, and then total claims-based and total non-claims-based. So that's the level of granularity that we collect for every single record. So with that, when we calculate the total, that number of primary care percentage, spend percentage, we add both the claims-based and the non-claims-based together. But then we can separate between, if we wanted to look only at the claims-based and look from the Colorado EPCD, we can pull that. But generally when we report on it, we combine them, at least when we report on it from the APM files. So.
Thank you. Are you able to display, sorry. This is actually a comment, if I can get to it. My screen just locked up. As a comment, it would be good to know the pharmacy-related expenses. I presume they're talking about the denominator here and how they relate to outcomes. Many times this information is siloed.
Yeah, that kind of as an addition to what Tara had mentioned before about, the primary care collaborative kind of driving the decision to remove pharmacy from the denominator. We also, based on the specifications that we have provided our payers, we told them not to include any pharmacy data because it's inherently medical data that we're collecting, because we're collecting at the billing provider level. So in that case, we would maybe add, a pharmacy level or something to be collecting that information. But just the inherent collection itself of this alternative payment model data is directly related to medical providers and not as related to pharmacy. So if we were to include pharmacy in the denominator, we would just take that from the Colorado APCD, which as it is right now, it theoretically should be the same selection criteria, Colorado residents, et cetera. But that can get a little dicey, if payers might have forgotten a certain population to be submitted to the APCD versus in their APM files. So it just gets a little complicated as you pull back the layers. So we've stayed away from that, but you're correct that it is siloed a little bit. Presents challenges.
Thank you. We have about 5 minutes left. I'm going to open it up. I have a general question, and maybe I'll ask Ose if he can respond to this first. What was the nature of the provider data, whether billing, rendering, or attending provider, that you had access to and used in your analysis in terms of provider specialty types? What were the strengths and limitations, and do you have any thoughts on process to improve any provider data limitations that you might have identified?
Yeah, so essentially we pulled provider data, and just going back to the definition, which I think Tara had described, we had modeled our own definition after what Milbank Memorial Fund did, and we used a narrower definition. We did not add OBGYN providers. We did not add geriatrics, and we also excluded I think adolescent medicine. So we used they called it the PCPB. So they had 4 different categories. From the very narrow A to D. So we used a narrow definition, and we looked at the number of services and also the allowed amounts. right? So, so based on, from the I think one of the response to the question where someone had asked why we do not use ERISA and the federal employee. So I think that is a little bit of, I mean, I wouldn't say weakness, but we would prefer for all data, for our data to be more complete than we have right now, because the ERISA and the pharmacy and the federal employee account for about 42%, about 44% of the data that we are supposed to get. So, however, we've done some internal studies. A sister agency of ours has done some studies on the data we have, and it is representative of the privately insured members in state of Maryland. Yeah. So, and again, I also believe doing some form of data linkages, as I think in some of the previous presentations, they had mentioned, data linkages and having data in silos. That could be something which in future, which we will hope to be able to overcome. Yeah.
Thank you. I'm going to turn to Colorado now and also ask the question about provider data. What did you see as the strengths and limitations in the provider data that you had to work with?
Yeah. Hi, this is Maria, and I'll take this one. As Tara mentioned and Julia mentioned also, so we have a definition, a primary care definition that is based in several things. What is who the providers are, what type of services they do, and the combination. So we use both. We use billing provider mostly to determine the primary taxonomies for primary care providers, but we also use the service providers in some cases because we wanted to capture those other services or models of services like behavioral health providers who provide service within a primary care environment. So we are using the service provider for the behavioral health provider and the billing provider for the primary care provider. We do the same for some specific taxonomies like physician assistants and nurse practitioners that might be practicing in very different environments like multi-specialty environments, and we don't want to read those. We want to read the ones that are in primary care settings. So that's the way we use primary billing and service provider both. But of course, there are some limitations that works only for those models where the integration happens in the same building and it is built through the primary care setting. But we know very well that there are other type of arrangements that we are not capturing, and we will need richer data, probably external data, to be able to place providers in the practices and be more able to characterize who are providing care in a primary care setting.
Thank you. Dolores or Jen, do you want to, I got about 1 minute left if you want to respond about California's provider data.
Yeah, I'll actually just make a comment a little bit more generally. I mean, we have, rendering and billing provider. We use that for different purposes for in the studies. But I think one of the things that I think is key is getting down to the code level. So this is actually related to a primary care spending study that we did, not the study that we presented here, but really like having a code list of what are the taxonomy codes that actually represent the types of clinicians that you want to include, right? That gets very specific instead of just having a broad category like include internists, include, adolescent medicine. If you have specific codes, it makes it much more consistent and comparable across organizations. And across states. So I think that starting to move toward more specificity, I think Colorado mentioned the Oregon code set that was used. Again, the more we can have codes for procedures or taxonomies, I think the more consistent that we can get results, and then they will be more comparable beyond just your own study. So.
Great. Thank you. I think we're just about out of time. So thank you all for your great presentations and work you've done in these states, moving the ball forward. Thank you.
Thank you very much.